Anticoagulation Associates, in partnership with WakeMed Health Systems. Anticoagulation Associates is a clinic where patients in the WakeMed Health System requiring anticoagulation therapy for various medical conditions have their labs monitored and medication therapy adjusted based on those labs. The clinic will be staffed by a hematologist that serves as medical director, a staff MD, and 7 nurse practitioners, as well as support from nursing staff and clerical staff. Our EMR module will transmit lab information as well as medication administration records and prescriptions written for patients seen in the clinic. You may be wondering, what can we do for you? CareStream Lab module provides more than just a way for any physician practice to go paperless. This comprehensive solution is the next generation for healthcare IT, allowing practices to improve efficiency and enhance patient care. Our platform is robust and allows any providers to electronically submit claims to payers. It is fully unified with WakeMed Health System's electronic medical record system and offered as part of our comprehensive EHR solution, giving our end user an answer to the challenges of managing practice workflow. How it works. Our CareStream allows flexibility for users to access our module from a variety of devices, including PCs, desktop, laptops, via internet, or LAN connection. This approach to EHR design minimizes or potentially eliminates the need for interfaces by providing true data level integration. This approach makes it easy to send and receive information whether you're in the office, an exam room, or at home. We make following the rules easy. Regulatory requirements. Demonstrating meaningful use is vital for the success of care providers and for the health of our community. Included in the strategies for demonstrating meaningful use is the electronic submission of reportable laboratory results. This is often referred to as electronic laboratory reporting, or ELR. A number of new requirements under meaningful use will impact labs both directly and indirectly. For providers, a number of lab orders must now be entered into the EHR through computerized physician order entry systems, or CPOEs, and they must be received electronically in a structured data format. Hospitals and physicians also must be measured by quality metrics that rely on lab data. HIPAA. Hospitals and providers are very aware of the need for compliance with HIPAA, but are not necessarily aware of all the potential vulnerabilities to protect health information. EMRs create a lot more potential for unauthorized use and disclosures because the information is much more readily available. The increased availability of private information may require increased vigilance by hospital leaders and employees. Although most health systems have HIPAA training and education programs, EMRs may necessitate a heightened awareness and recognition of the specific challenges that an electronic database presents. ICD-9 coding and billing. Medicare and other insurance payers frequently audit our patients' bills together with documented orders and diagnoses written in the patient medical records. This is to ensure that only those procedures ordered are billed for. Furthermore, the procedures ordered must be deemed medically necessary. That is, it is documented that the patient demonstrates signs and symptoms which justify the test ordered. Correct CPT coding is the responsibility of the provider of diagnostic services. The first step of moving forward with the implementation of any EMR system is assessing needs and readiness of the user. In our clinic, we have examined the readiness of the people who will use the new system, their training needs and capabilities, the technology and equipment required, and the need for new policies and procedures. The assessment is also an important opportunity to build a consensus for change based on needs. For example, clerical staff spending much of their time notifying patients of lab results and next steps. Even more time is dedicated to this process if unable to reach the patient. The new system and its users will need to collaborate, harmonize, and centralize. Leadership commitment equals clinical engagement. Communicate an improved process that resonates the local needs and its benefits. Example, clerical staff not tied to phones all day. Physicians can easily make dosage changes in real time when they receive the lab results and establish and adhere to a timeline. Training and education. For the staff, initial training will take several sessions. First, we will focus efforts on those most resistant to the change and ensure that everyone has computer skills required to operate the system. Training will start several months ahead of rollout. It will be ongoing for new staff after the initial startup, and patients will be educated at each clinic visit about the new workflow process and given resources for assistance. And now, to lay the groundwork. To make the go-live day as smooth as possible, we will also need to plan for installation of new hardware and software, preload demographics of current patients, establish network security and harmonization, develop a growing super user pool, and plan for overstaffing for the initial go-live period. Go live. This is the big day. Make sure you use super user pool staffing to ensure adequate assistance during this initial period. After a week or two, fewer super users will be needed, and by week 5, they will be available on an on-call basis only. Logistical support will be on site during the entire initial period. Daily huddles with your team to review what happened the day before, lessons learned, and preview the coming day. Sustainability. There are 4 steps involved here: revise, reassign, retrain, and assimilate. Revise any major workflow issues. Reassign roles to better meet new processes. Retrain as necessary on the new system. Assimilate to the new culture. While this graphic shows a one-way process, many of the steps overlap and are interrelated. We have chosen to use the Plan, Do, Study, Act quality improvement method. The PDSA cycle will allow us to create measurable objectives, test small-scale changes, study the effects of implementation, and make changes as necessary. Well, in the planning stages of the QI process, we've determined that the objective of implementing this EMR module is to increase efficiency of communication between our practice, anticoagulation associates, and our primary payer, Medicare. We can evaluate our progress towards reaching this objective by measuring our performance on the following indicators: number of claims denials, wait time for medication change approvals, and timely payer reimbursements. We have established a baseline measurement of these indicators and aim to reduce claim denials by 50%, decrease wait times for medication change approvals by 75%, and decrease time for reimbursement by 50%. While much of the do phase is outlined by the implementation strategy, there are a few points to maximize. First, building in time or even lighter patient loads for practitioner piloting a module will help to minimize clinical operations while gaining feedback on the ease and use of the efficiency of the module. Documentation of observations in the do phase, both positive and constructive, reinforces the benefits of the module and creates a list of new issues to address during the next do phase of the cycle. This will also keep the end users engaged as they are ensured that their feedback is valuable and will be used when able. During the study phase of the PDSA cycle, feedback from end users will be collected and aggregated. Progress towards a measurable goal will also be compared to the baseline data. Solution to problem identified during the pilot testing will be implemented in the ACT phase. The PDSA cycle can be repeated based on new information learned during the initial cycle. And now you may be wondering, what's it going to cost you? The cost of implementing an EHR can vary greatly depending on many different factors. Some of these factors include the brand, how many functions are involved, and how many providers the EHR serves. Several studies estimate the cost of purchasing and installing an EHR, or electronic health record, range from $15,000 to $70,000 per provider. This cost can vary depending on whether you select an on-site or a web-based EHR deployment system. Web-based EHR deployment is known as software as a service, typically requires providers to pay a fixed monthly subscription cost. On-site deployment typically requires providers to pay for ongoing costs to support and manage on-site data servers. There are 5 main components of EMR implementations that have an impact on the cost. These include implementation assistance. Potential implementation assistance costs include IT contractors, attorneys, electrician, and/or consultant support, chart conversion, hardware network installation, and workflow redesign support. Training. Your organization will need to train your physicians, nurses, and office staff before and during the EHR implementation. Physicians, nurses, and office staff should know how to use the EHR and associated hardware and how the EHR will create new workflows for the practice. Ongoing network fees and maintenance. There is the potential cost of hardware and software license, maintenance agreements, ongoing staff education, telecom fees, IT support fees. Additionally, new staff may need to be hired to work with this EHR system, including IT operations staff, clinical data analyst, or application analyst. EHR software. Potential software costs include an EHR application, interface modules like our lab interface module, and upgrades to your EHR applications. Software costs vary depending on whether you select on-site or web-based deployment options. Hardware. Potential hardware costs may include database servers, desktop computers, laptops, printers, and scanners. Although there are high costs associated with implementing an EHR, these costs can be offset over time. EHRs help practices reduce the cost of providing care in many ways. Other savings include reducing administrative cost, minimizing claims denials and lost charges, reduction of wasted time reviewing results of duplicate tests, reduction of running duplicate tests/procedures. Additionally, the Centers for Medicaid and Medicare Services grant an incentive payment to eligible professionals or eligible hospitals who can demonstrate that they have engaged in efforts to adopt, implement, or upgrade certified EHR technology. According to a study published in Health Affairs, most practices are able to cover the cost of their EHR system in approximately 2.5 years, and then receive an average of approximately $23,000 per year per full-time employee in net benefits. Other studies show that after integration of the EMR, groups saw a return investment from increased cost efficiency. The new EMR saved this particular practice $114,000 in its first year of operation. Projected costs. You can expect to see revenue increases from an accurate, higher level coding and efficiency related savings. EHR care is designed as a typical long-term care. A variety of investments are needed to support the EHR system. We project a 5-year cost to include investments in the area of software and interface, different and additional computer devices, system hosting, systems to help manage the support for users, telecommunication costs for added bandwidth and wireless networks within facilities. We specialize in connecting stakeholders, you, your patients, third-party insurers, and other clinicians. CareStream's health modules, helping people reach their potential. And now we've come to the end of our presentation. Or, with the aid of CareStream EHR module, the beginning of your future.